Okay, Scottish Medicine Consortium do something rather similar to NICE, but do it in Scotland. What's quite interesting about Scottish Medicine Consortium is that they explicitly came up with a list of what they've called modifiers and reasons for being willing to spend a bit more for a QALY. And their modifiers, some of them, I've listed here. So for example, if the drug you're looking at is a bridge to some definitive therapy, for example, a bridge to transplant, so this drug keeps you alive or makes you healthy enough to reach transplant, that might be a reason for valuing them a bit more highly. Another quite interesting one here is sometimes the new drug will be replacing or an alternative to something that's unlicensed or is being used more strictly off-label. A drug might have a license, but not for this condition, a license for some other condition. And this is a real sort of pharmacologist's regulation type thing. They like the idea that the new drug has a license. The new drug has evidence and has then got approved, in our case, by something called the European Medicines Agency. And so it's going to replace an unlicensed, or strictly speaking, off-label therapy. Now, I don't think that's a very good reason for being willing to spend a bit more for a health benefit, but it is used. Okay, National Screening Committee also use cost-effectiveness information. National Screening Committee is a body set up to make decisions on screening programs, and they'll use cost-effectiveness evidence. So in England, or indeed UK, we screen for colorectal cancer. Not every country does. And we do it because the evidence suggests it's effective, and more than that, it suggests it's cost effective. So it has an influence. I'll leave that. Yes, I mentioned this as one of the activities I did for indeed 8 years. I sat on this committee, the safety of blood, tissues and organs. And this committee explicitly considers cost effectiveness. But quite important to note, it doesn't just look at cost effectiveness, but it considers other arguments, for example, the need to maintain adequate supplies of blood products. And so when this committee was looking at different interventions, and here's some examples of interventions, pathogen inactivation of platelets. So essentially you're making the blood product platelets safer by inactivating pathogens. Another example is instead of getting platelets from single donors, the process is called apheresis. Instead of single donor apheresis, you can get the platelets from pooled whole blood donations. Now, the pooled whole blood donation is cheaper, but riskier, because you've got lots of individuals, as it were, contributing their risks to the pool. Whereas if you're getting your platelets from single donors, you can be much more sure that that donor's platelets are not so risky. One quite recent one is screening for hepatitis E, HEV. Now again, all of these, we look at cost effectiveness as one of the main arguments. As a consequence, we didn't introduce pathogen inactivation of platelets. We did introduce screening of blood donation. I think we said no to prior infiltration of red blood cells, but we said yes to the importation of fresh frozen plasma to reduce the risk of variant CJD. Now, you can't see this. This is very irritating when any speaker says this, but you can maybe make it out on your handout. This is the sort of decision-making grid. The key point here is value for money is a consideration, but it's not the only consideration. And so we explicitly look at other factors. JCVI, something similar. I'm conscious time has left us. This is Joint Committee on Vaccination Immunisation. And again, cost effectiveness is an important consideration. Got an example. Not that bit. Meningococcal B vaccination. When we looked at the cost effectiveness of it, there was a pretty low price at which a programme of vaccinating infants would be cost effective. It was a fairly low price. On the other hand, when we looked at adolescents and giving them the vaccination, it wasn't possible to find a positive price at which it would be cost effective. And so the cost effectiveness was instrumental in deciding to introduce the vaccine programme for infants and to say no to adolescents. Now, let me stress, it's not that it doesn't work in adolescents, but it doesn't work well enough given the cost of the vaccine. And I won't go through these. I'll just get to my summary. There are a number of challenges involved in using economic evaluation to inform decision making. Perhaps the biggest one is producing robust estimates of cost effectiveness. Now, I've rather blithely said we can compare the cost effectiveness estimate with the threshold. But to calculate the cost effectiveness, the cost per additional QALY gained for these different interventions is not straightforward. And the evidence that is available to be used is frequently not very strong. And so, perhaps the biggest challenge, if you want to use economic evidence, is coming up with robust estimates of cost effectiveness. And the next lecture and lecture tomorrow morning are very much looking at some of these issues. Next challenge, well, this is what I started with. You have to decide on a cost effectiveness threshold. What represents good value? Now, I'm suggesting that you could look at what gets displaced. It's a nice idea, but again, it's not the simplest task, identifying the value of what's displaced. And then, what other factors, other than cost effectiveness, should be included? And then the final challenge is this. Health economists love economic evaluation. To us, it's bread and butter. It's better than bread and butter. It's lifeblood. The rest of society, of course, is not quite as up for economic evaluation. And there's a wide range of stakeholders, patient groups, pharmaceutical industry, clinicians, politicians. All these other groups really want a series of yes decisions. People don't like to hear no you're not going to get access to this technology. They don't like to hear that. And so the final challenge here is, how do you say no sometimes and yes sometimes and keep stakeholders engaged? And that's a tricky task, because you need the industry, you need clinician groups, you need patient groups to some extent to sort of buy into the system and to accept it. And indeed you need your politicians to do so as well. So those are the challenges. And sorry for having to just overrun slightly, but I can blame the technical challenges at the start. Okay, we'll have plenty of time for questions in other sessions, so I won't keep you from lunch and your well-earned lunch break. Do we start again at 1? 1 o'clock, yeah. And so just to remind you, what we're going to move on to is what's at the heart of many economic evaluations, and that is predicting what's going to happen to patients if we don't treat them or if we do treat them with the new technology. And it's that's the engine that drives most economic evaluations, because the time patients spend in different health states will influence the costs and influence the benefits. Okay? Thank you.